Okay, let's dive right into this incredibly exciting topic, the great clinical trial modernization. Look, if you ever felt like medical research is just bogged down by these rigid, paper-heavy, bureaucratic processes, well, you're not alone. But the good news, we are literally right in the middle of a massive evolution. Global regulatory guidelines are actively being rewritten as we speak to finally shed that past. And in this explainer, we're going to break down exactly what that transition looks like. We're talking about moving from a world of endless, dusty filing cabinets to a streamlined, patient-centric reality. And trust me, the impact this is going to have on drug development timelines, it is going to be absolutely profound.
So, here's our roadmap for today. First, modernizing clinical trials. Then, out with the old. Next, the E6R3 overhaul. And finally, a patient-centric future. Let's get to it. Now, when we examine the regulatory blueprint for this shift, we can actually map out the exact additions and reductions that are completely transforming clinical trials on a global scale. This isn't just theoretical anymore, guys. We're seeing a calculated industry-wide shift away from those traditional, rigid frameworks and moving toward a highly dynamic, digital-first approach. By reevaluating these long-held standards, regulatory bodies are actively clearing the path for real innovation. So let's unpack exactly what this means for the future of medicine and how these structural shifts translate to actual operational reality.
Part 1. Modernizing clinical trials. Looking at the broad updates happening across the industry, we see this sweeping modernization effort aimed at catching issues before they even start. Take the E8R1 guideline, for instance. We're finally moving away from constantly putting out fires with reactive protocol corrections, and instead we're embracing quality by design. It's all about better planning from day one. And speaking of efficiency, Guideline E19 tackles the elephant in the room, collecting excessive non-critical data just in case. By allowing selective safety data collection, the operational burden is just vastly reduced. Add in E20 and E17, which are paving the way for adaptive, simultaneous global studies, and E9R1's Estimins framework, which clears up that traditional endpoint ambiguity, and what do you get? You get an ecosystem that is literally built for speed, clarity, and true statistical precision. It's a fundamental reimagining of protocol design.
Part 2. Out with the old. Now, if we're going to build a new foundation, we've got to acknowledge what we're finally leaving behind. For decades, 100% source data verification was the unquestioned gold standard, right? Every single data point had to be manually checked against the source document. It created this unbelievable bottleneck of paperwork, wasted hours, and honestly, staggering costs. Well, the industry is officially acknowledging that verifying every single piece of source data manually is just too expensive and inefficient to sustain. Seeing this officially designated as a reduced concept is a monumental shift for trial organizers everywhere. It frees up massive amounts of clinical resources for what actually matters: patient care and higher-level analysis.
And that leads us perfectly into the next major reduction, the end of excessive on-site monitoring. We are finally saying goodbye to physical filing cabinets and those days of site monitors constantly traveling from clinic to clinic, just drowning in paper-heavy documentation. Why? Because centralized monitoring has become highly effective. By adopting streamlined, digital, cloud-based systems, we simply don't need that heavy on-site footprint anymore. We can monitor data trends centrally, identify risk signals, and catch anomalies way faster than a human manually flipping through a paper binder ever could. It is a massive win for both data quality and trial budgets.
This shift right here fundamentally alters how compliance is viewed. Regulatory frameworks are now explicitly stating that risk-based flexibility is preferred over rigid checklist compliance. You know, the old mentality often meant treating a minor typo with the exact same urgency as a critical safety risk. It forced teams to just chase their tails over completely inconsequential deviations. But now, systems are actually designed to weigh the real impact, allowing teams to prioritize patient safety, data integrity, and operational efficiency over mindless box ticking. It really empowers clinical professionals to, actually use their professional judgment.
Part 3. The E6R3 overhaul. The source material doesn't hold back on this one. It explicitly positions E6R3 as a massive GCP modernization, and it really is. This isn't just a minor update or some slight little revision. It's a foundational overhaul necessitated by the rapid rise of decentralized trials and digital systems. Transitioning good clinical practice from a rigid traditional approach to a flexible, modern, risk-based standard is arguably the most significant operational shift the industry has navigated in our lifetimes. It completely rewrites the rules of engagement to reflect how modern clinical research is actually conducted today. When we group the most impactful additions within E6R3, a super clear, interconnected theme of digital innovation emerges. It starts at the very beginning with e-consent, allowing patients to review, understand, and sign documents dynamically on a tablet from anywhere. From there, we move straight into e-source data, creating direct electronic records right at the point of care. That completely eliminates the paper middleman and all those annoying transcription errors. And perhaps most notably, we see the formal integration of wearables. Continuous patient monitoring, like say capturing heart rate or movement data passively through a smartwatch, is seamlessly written right into the trial framework. This is the new standard of robust, real-world data capture.
But of course, all that continuous data streaming in from wearables, decentralized sites, and remote devices, well, it creates a new vulnerability. You need a better shield. And that is exactly why we see robust additions focused on risk-based quality management. This means trial runners focus their proactive oversight on the critical, systemic risks that actually matter to the study's outcome. Alongside that, we get strict data governance rules. As our systems open up to the cloud and we integrate all these disparate data sources, ensuring data integrity and vital cybersecurity against external threats becomes an explicit regulatory requirement. Basically, it's about protecting the data just as much as collecting it.
Now, this specific addition, the proportionality principle, is a total game changer for oversight. It ensures that monitoring is tailored and flexible rather than universally prescriptive. Think about it like this. If a trial is testing a simple, well-understood over-the-counter intervention, the oversight can be scaled proportionally to that low risk, saving vast amounts of time and money. Conversely, a novel gene therapy, that would demand highly rigorous, intensive monitoring. It replaces that rigid one-size-fits-all approach with context-aware management. It matches the level of scrutiny to the actual clinical reality without ever sacrificing patient safety.
Part 4. A Patient-Centric Future.
By formally embracing decentralized trials, or DCTs, the guidelines are fundamentally changing the geography of research. Think about what this means. We are bringing the trial to the patient's home, rather than forcing the patient to constantly disrupt their entire life to travel to a site. Remote participation is a massive addition because it directly solves one of the industry's oldest and most persistent problems, which is retention and diversity. People who previously couldn't join a trial because they lived too far from a major research hospital or who simply couldn't take time off work for frequent site visits, they now have equitable access to cutting-edge medicine.
Looking at the whole picture, the entire paradigm has fundamentally shifted. We are moving away from a rigid, process-first mentality, where patients had to conform to the demanding schedules of large clinical buildings, and we're moving toward a dynamic, participant-centric design. Everything we've covered today, from reading e-consent on your couch, to wearing a smart monitor that passively collects data, to eliminating unnecessary and burdensome on-site visits, it all serves a single, unifying purpose. It's all about making the trial work seamlessly within the participant's daily life, not the other way around.
Which leaves us with an incredibly compelling question. As the global industry fully adopts these modernized, flexible, and digital-first frameworks, how much faster will the next life-saving treatment reach the public? By eliminating decades-old roadblocks, reducing administrative bloat, and fully embracing this regulatory blueprint, the timeline from a lab discovery to a life-saving treatment just got significantly shorter. And honestly, that is a future worth watching. Thanks so much for joining us for this explainer. We'll see you next time.